Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, my name is Stephen Schaefer, and I'm excited to bring to you what is going to be a great conversation with an expert clinician. Our guest today is Dr. Sarah Cristello. She received a doctorate in physical therapy from Acadia University in Philadelphia, and then after working in private practice, Dr. Cristello joined Brooks Rehabilitation in 2009, where she has filled a variety of managerial roles. In addition, she completed the Brooks UNF Orthopedic Residency in 2011 and gained certification as a board specialist in orthopedics in 2012. Then, at the same institution, she completed fellowship training in orthopedic manual physical therapy. Currently, Dr. Cristello has a dual role within Brooks Rehabilitation, serving both as the OMPT Fellowship Coordinator and the Outpatient Services Supervisor. Dr. Cristello's clinical specialization is within spinal conditions, which is very much related to the reason we asked her to join us today. Dr. Cristello, welcome to the show.
Thank you. Thanks for having me.
We are excited to have you here today, and let's start just by saying that the reason we've brought you here today is to talk about pelvic floor dysfunction as it relates to orthopedic manual physical therapy. Can you tell us how you got involved in this general part of orthopedics?
So I think it kind of can go back to when you say you don't know what you don't know, but through my residency and fellowship training, I work at an institution where I'm really lucky. We have multiple residencies, and one of those is a women's health residency. So anytime I would get stuck with a patient, I had an ability to kind of pull in that consultative practice model. And, sure enough, there was something going on in the pelvic floor or the pelvic girdle that when working with the women's health therapist, we could really kind of get that patient over their hump and move towards recovery. So the more I started considering it as a possible, related impairment or a related region to treat, I was like, oh, I'd find things that were relevant and would work with that specialist, and we would, help patients. And so I found myself reaching out to them more and more and more and finding more and more cases where there was a connection. So through that, which is interesting as we talk about this, I am actually not trained in women's health. I do not see that patient population. I've had some courses, and that's mostly working with the women's health coordinator, residency coordinator at my institution. But through that, I've really just gained a great appreciation for recognizing when patients probably should be seen by a women's health therapist. And we have several in our system, and so I coordinate with them as opposed to being that therapist for them.
That sounds excellent and perhaps precisely what our audience would benefit from, and that is, as orthopedic manual physical therapists, we're not necessarily pelvic floor specialists, but if you fail to identify when you need to collaborate with one, then that's obviously a problem. And building off that point, I imagine, though you did not say this specifically, that you're talking about patients with hip pain or back pain or thigh pain that initially you perceive as being maybe more of a traditional orthopedic patient. But it turns out that the skills that you learned in those training programs weren't quite enough, and you have to go towards collaborating with that pelvic floor specialist.
Yeah, I mean, that's exactly it. So, sometimes you have somebody that comes in and you think that there is a proximal hamstring issue. And so, following the evidence, working through all of those things as you know to do as an orthopedic specialist. And at the end of the day, they're not quite getting to where you would expect them to get. You consult with a women's health therapist and come to find out they have a significant amount of pelvic floor muscle guarding. They had a pregnancy 3 years ago with some tearing, and you put the picture together and they start to do some internal pelvic floor work, and there you go, their hamstring problem resolves. So, sometimes there's both. Sometimes, in my experience, it's a primary pelvic floor dysfunction that presents as a hip, low back, or kind of buttock pain. And other times it is a primary low back or hip type presentation. It just has some components of a pelvic floor dysfunction. And when you don't treat the whole patient, you only get a little bit better instead of helping them, really achieve their goals.
That sounds very consistent with how we approach pretty much every musculoskeletal situation in the whole body.
Mhm.
Mostly neck, partly shoulder, or vice versa. It jives with my understanding of orthopedics. Now, one of the things, of course, that's really important here is understanding how prevalent these conditions are. Is this the type of thing that you see in 1% of your patients, in 50%? Like, how would you characterize the prevalence of this type of situation?
I think that could be a funny question because, I'm sure you've worked with therapists as well that don't even think that the pelvis sort of exists. So if you're not looking for it, it doesn't ever happen. And then you could really go on the other end of the spectrum and say, when you're looking for it, every single patient needs pelvic floor work. So, there's obviously some in between. But if we look at like the literature from a prevalence standpoint, about 25% of women in the US have some form of either urinary or fecal incontinence or pelvic organ prolapse. So that's a good number, 1 in 4. But I think what might even mean more to us, kind of as orthopedic therapists and looking through that lens, if we think about the connection of pelvic dysfunction or pelvic floor issues and low back pain, 78% of patients, I think that's female patients, actually, 78% of female patients with low back pain have some form of urinary incontinence, maybe very, very mild that only happens when they're really sick with an intense cough, but some form of urinary incontinence. And then there are studies that show that there's decreased pelvic floor muscle function in patients with low back pain when you compare those to patients, norms without low back pain. And then that relationship's even stronger when you kind of put in pelvic pain or sacroiliac related pain and pregnancy related pain. To say what percent of the population of the patients that I saw, I don't know. I just think that it's more prevalent than anyone probably considers or realizes.
I like the nuance of your answer. Of course, these things aren't always clear cut. It depends how you characterize them or what demographics you look at. But the basic message I hear from you is that it's prevalent enough that if you're not looking for it, you're missing it on a regular basis.
Yeah, I would agree with that. I would definitely agree with that.
So you mentioned the example that I think the largest number of people are probably familiar with, and that is low back pain, especially chronic low back pain, can lead to a situation where there's urinary incontinence. And then, of course, we dive into automatically suggesting that everyone needs Kegel exercises, which I know isn't necessarily the best advice. But are there other ways that you see this manifest in terms of, as an orthopedic specialist, when you're looking for things? Is it just that, or are you looking for other things as well?
So, it's not just, well, I mean, that's a hard question. So, I think you really have to go back to just the basic anatomy of what is the pelvic floor and what is the pelvic girdle. And then you can start to figure out how this might manifest clinically in all sorts of different ways. And I say that because sometimes it manifests as what looks like a peripheralized low back pain with a patient that's got, radiating pain to their foot. And other times it's pure sort of buttock pain. What I would recommend is just sort of thinking about the anatomy. And so when we think about the anatomy, we can think about the bony pelvis and the pelvic girdle and that role that it has in supporting the abdomen and the organs of the pelvis. So then you've got the link of the pelvis to the spine. So, you've got your L5S1 region. You've also got the link of the hips or the femur to the pelvic ring. So that's another area to consider. And so any kind of dysfunction in that joint system could manifest. But, then we also have the passive structures, the ligamentous structures in there that can be sources of pain or referred pain. Then next, you could start to say, we have more of our dynamic system. So sometimes it's fun. I like to just, like, when I'm having trouble with a patient, just Google the trigger point referral patterns. And you're like, oh, yeah, that's sort of an interesting pattern. But you can get a lot of pelvic floor muscles that can refer to, posterior thigh, which looks similar to maybe a piriformis guarding or hamstring problem, something like that. And then I think another thing to think about clinically for us as orthopedic therapists is really just some of the associated muscle groups and facilitatory muscle groups. So when we think about the pelvic floor and its role in supporting the pelvic organs, but also having a role in sexual function, there are other muscle groups that are associated with that. And so that's the piriformis, the obturator internus, and some of those other hip rotators. Then we have facilitatory muscles, which are like the hip adductors, the glutes, the transverse abdominis. So anytime there's a dysfunction in, again, the bony anatomy, the passive structures, the dynamic structures, you can think about all the combinations of how that might manifest clinically for us. And then another thing I think I'm making this assumption, but it's sort of what I've observed in the institution with the therapists that I work with, is the lack of appreciation for the synergy between the transverse abdominis, the deep lumbar multifidus, the pelvic floor, and then the diaphragm. So, I don't know if this is a saying around, but this is what we say in our institution. We say, the floor to the core, the pelvic floor is the floor to the core. And oftentimes it could manifest simply as somebody having low back pain with movement coordination dysfunction and us not appreciating where that pelvic floor comes in as a need of a system that they need better stability in, or motor control in. And then, not to go too far off, because I'm not a women's health therapist, so I don't talk quite as openly about it as if women's health therapists, they're just really open. But the other kind of rhyme where you could say S2, 3, and 4, keep the pee and poo off the floor. So essentially considering nervous system dysfunctions, whether that's more centrally or peripherally, but how any compromise to some of those peripheral nerves in the region, the pudendal nerve, for instance, being a big one, or more nerve root issues, how that might manifest clinically. So going on this anatomy rant, but like, to get back to your question about how does it manifest clinically, I think any dysfunction in that anatomical group is something that we need to consider. And so, how does that look to us from a kind of women's health lens, I guess? That would be, lower urinary tract symptoms such as incontinence, urgency, frequency, sexual symptoms, and oftentimes that might be pain, bowel problems, constipation or incontinence, pelvic organ prolapse, so a lot of pressure, heaviness in the pelvis, pelvic girdle pain, and then low back pain. So that's kind of where we come in, is recognizing when there's pain in the pelvic girdle region, hip, low back, buttock, upper thigh, groin, medial thigh, or pain in the low back, considering the anatomical connections to that pelvic floor. So that's a long-winded answer, but essentially it could manifest in lots of different ways. And so appreciating, I think, the anatomy is probably the best place to go in order to kind of think through how that might match a patient that's in front of you.
If I could offer a slight rewording, I would just say it's actually not that long-winded, because you could probably fill a 3-day course with this content. So let's call that a nice little snapshot of the overall breadth of the topic.
Okay, that sounds good to me then.
Listening to you give this answer, you made me think of several things, and I'm not sure if they'll all come back to my mind right now, but one of them is, are you familiar with this study? I believe the author is Torstensen, and it was published in 2015. They did a palpation examination of pelvic floor structures, and then they just simply, I believe, asked the female subjects, where do you feel the symptoms? And yes, of course, a lot of the pain, the local pain, the referred pain, was in and around the pelvic region. But they very clearly reproduce symptoms all the way up to the neck and all the way down to the bottoms of the feet when doing a pelvic exam.
Oh, I'm not familiar with that study, but it doesn't surprise me.
No, to anybody that's worked in any part of the lumbopelvic region, it should not surprise them. And one of my favorite parts about this study, and I pull it out when I'm educating my patients, is they have a really nice visual. And the visual shows with all this red dotting. Here's where different subjects felt the pain. And of course, it's more red. There are more dots in and around the pelvis. But it is just amazing how far the referral patterns go.
Yeah, and I mean, and that's very similar. There are some of those studies that show the same thing with like facets, right? So you could inject an L3-4 facet and get pain, a right facet and get pain on the left side, and all sorts of below the knee and all of those things. So yeah, it's definitely interesting. I'll have to look that one up though.
It's almost like you're saying that the pelvis, with bone and muscle and other similar structures located within it, is just like other musculoskeletal regions.
Yeah, I think you nailed it. Yeah, that's exactly it. And so I think sometimes there's this, I don't know if it's a fear or I don't know what it is, but we tend to forget about the pelvis, and it falls right between the low back and the hip. And it is just a musculoskeletal system, like you said, similar to all of our other the regions that we treat more comfortably.
Yeah, I think that's exactly right. And of course, as is the case with most things, I think it's multifactorial. In my case, for example, I don't think anyway that I learned about pelvic floor health when I was in my physical therapy training program. I'm pretty sure we didn't cover it except maybe the SIJ in my residency training. And we minimally got into it in my fellowship training, but it was, in that instance, it's more of the here's how it relates to low back pain and incontinence. We didn't, for example, learn, internal pelvic exams or rectal exams. And just like you, I'm not clinically qualified to be that specialist, but I do use my other OMPT skills to try and figure out when I need to rely on those folks. And sometimes, honestly, it's just my failure. Like if I fail to find the origin of the hip pain, I'm thinking everything from MRI and surgeon to another physical therapist that has a different skill set than mine. So it's always on the forefront of my brain.
Yeah, and I think that's extremely important skill set, through our fellowship that we really tried to instill is it's almost like a little bit of a humbleness just to say there are things that are beyond my expertise. And so who might I need to work with, or whether that's more of the medical management or another physical therapist or specialist. So getting comfortable with not knowing everything, but then knowing enough to know who to refer to, who that right person probably is.
It's a great way to word it. And one of the things that you make me think about is a patient I saw. This is actually some number of years ago. Young female. At that point, she had chronic low back pain. I think she was going on 3 years. And she ended up in the office of a provider who, because her back pain referred to her lower abdomen, the provider was a little bit, probably a lot dismissive and ended up just telling her to go see her OBGYN. And I thought of this because when you were talking about the different ways that it could manifest, you talked about all the different, anatomical tissues that are related to pelvic floor function. So it could be vaginal, it could be anal, it could be reproductive, it could be urinary, it could be sexual. And the provider in her instance didn't ask any of those questions.
Hmm.
She expressed to me like, oh, here's what they thought. And I thought it, was ridiculous. So I never went to see my OBGYN. And I mean, that could be good or bad. You don't know until you ask the questions. So, I sat there and I asked her questions relative to health that is specific for a female. And every single question I asked was no, 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 I don't have those problems. So then it told me that it was less likely to be in that realm of healthcare. So we went back to the more traditional physical therapy MSK examination.
Yeah, I mean, and that's exactly it, right? So a good thorough history will help you, and I think that's somewhere where I've gained some efficiency in this population of when to refer and who to refer to. It really always comes back to the questions that I'm asking the patient, maybe less than that exam because I've been trained a little bit in an internal pelvic floor exam, but it's not something that if you asked me to do 20 minutes from now I would want to do. I would not feel comfortable there. So I revert back to that thorough history.
So you mentioned, and I mentioned as well previously, that there are these questions that we ask. But how about when it comes to the physical exam? Is there any special test you do, any tissue that you palpate, anything physically that's going to help direct you towards referring to a pelvic floor specialist versus either keeping that patient within your own caseload or perhaps finding someone else like a medical provider?
So I'm gonna take your question. I'm gonna put it on hold because I do want to talk a little bit more about the history questions if you can, because I think that will then help me answer your question about where to go. And so when you go to the history, the one thing I think that we probably do have comfort with is incontinence and low back pain. And so oftentimes when we're screening patients we think has a primary, musculoskeletal presentation involving a region that's not the pelvis, we screen for incontinence, but we don't consider other things. And so some of those other buckets that we would want to consider in our history to start really even to think, should I do some sort of exam? Because assessing the pelvic floor region when somebody comes in for low back pain and you want to assess their pelvic floor, that might not make sense to them. So when you start to think about the patient comfort or any liability claims or something like that, versus if I'm coming in to see a women's health therapist, I expect you to be examining and palpating in my pelvis. So I think if we can use our history questions to narrow down who we might actually examine first, that's helpful. So The way I would think about it is there's a couple of buckets, and within those buckets, types of conditions or presentations that we would want to ask about. And really, they're all of the buckets are related to an underperforming pelvic floor. So what causes an underperforming pelvic floor, or what are the manifestations of an underperforming pelvic floor that go beyond incontinence? So, one bucket would be intra-abdominal pressure, so causes of increased intra-abdominal pressure. So history questions might include things about like COPD, asthma, obesity. Do you have a chronic cough? Do you have chronic constipation? So, IBS type symptoms. Do you have a job, in the past or currently that requires a lot of repetitive lifting or even a high impact exercise? So sometimes some of the therapists I've worked with have worked with, teenage girls who are gymnasts and have a lot of impact in jumping in their daily activities and thus so have an underperforming pelvic floor. And then the next bucket, which I think makes a lot of sense, is related to pregnancies. So, have you been pregnant? How many times have you been pregnant? How did you deliver? Because with those things, come histories of nerve tractions or compressions, just that compression and weakness it causes to the pelvic floor, and then any loss of muscle integrity due to episiotomy or tears. So asking history questions in that area. And then considering age. So as we age, we lose pelvic floor muscle function related to a lot of changes in both striated and smooth muscles and neurotransmission, but just that consideration for age. So, as somebody's older with low back pain, it might be higher on your list to start to check out some of these buckets. And surgical, any surgery in the pelvic region is something to consider. And then, lastly, questions for men, which is not as common, but 5 to 20% of men do have urinary leakage. And oftentimes that's related to diabetes, prostate issues or prostate interventions, and then Parkinson's disease. So if you go through that history, you might be able to determine this is a patient with low back pain that I do want to do a pelvic floor exam on. And then this is a patient I don't want to do a pelvic floor exam on. And then for me as a non-women's health therapist, that pelvic floor exam really is an external pelvic floor palpation where I might check there's a power rating that pelvic health therapists traditionally use, but I might check their endurance. So, ultimate goal would be 10 pelvic floor muscle contractions held for 10 seconds and then followed by 10 quick flick contractions. And so with that, can they do it? Can they do it the full amount? Are there any compensations of, hip adductors or abdominals or glutes or those types of things? And then I look to other exam pieces that I might for, like a musculoskeletal type, lens of a lumbar exam. Oftentimes, maybe that includes a SI joint type cluster and then tests of load transfer. So for instance, the active straight leg raise test. And then beyond that, I think it's really whatever your framework is. Everybody has a different framework for how they approach a physical exam. And so mine often includes, just palpation, joint mobility, and then some static and dynamic observational techniques. So really different than any other exam when I'm coming at it from a musculoskeletal kind of primary low back pain lens would probably just be that external pelvic floor palpation and some good history questions. And then I think you asked me about then how do I refer? How do I decide who I'm referring or who I'm treating? And for me, and that's really kind of through the guidance of the women's health or pelvic health therapists that I've worked with, it really comes down to probably the complexity of what I learned through that history. And then, like you said earlier, failure or, through my treatment monitoring, if I'm getting to a point where they're not progressing as quickly as I want. So, they advise me and how I work with the residents and fellows in our system is to say, probably for a basic stress incontinence or movement coordination impairment type patient, so somebody that falls into that stability type category, probably appropriate to keep on your caseload and do things such as Kegel exercises, Kegel with breathing exercises, TRA Kegel breathing exercises, or anything where you're starting to pull in, extremities and core, and whether that's multiplanar, uniplanar, you guys know how to do that part in your exercise progression. And then beyond that, it's probably where a consult via email or phone is probably necessary to determine, am I sending them to you right away? sending them to the pelvic therapist right away, or am I treating with their advice and hopefully not having to send to them, or am I sending to them, one time for an internal screen, and then they'll send the patient back to me for me to, progress based on their guidance. So, but to kind of sum that up off of the history, it's probably more those basic stress incontinence patients and basic movement coordination impairment patients, or where that underperforming pelvic floor really is secondary to, or that related impairment to a primary, lumbopelvic kind of traditional presentation, versus it becoming more of the primary issue that's manifesting as low back pain.
And do you use any tools to help you with that? So, for example, a self report outcome measure or some sort of intake process, or do you just ask all of those while you're, for example, typing down your subjective data?
So there are really good, validated screening tools, and I don't know them. I don't know the formal names off the top of my head. They're in our system's intake paperwork already. So there's a couple that are just 3 questions about incontinence that are really good, but I'd have to, get back to you on some resources of what some of the more formal, named screening tools are.
That sounds like a really good point. From a clinical standpoint, I'm sure you find, roughly speaking, the same thing I do, which is tools like that were more helpful earlier in our careers. But at this point, we have become comfortable enough with the topic and the research and the different questions that, and maybe it's not perfect, but I can ask enough questions where I can typically determine whether or not I need to or don't need to refer the patient off to a pelvic floor specialist.
Yes, I'd agree with that. And even so, I mean, sometimes I've made even more recently some interesting mistakes. And so I still, I think when I have time, I'm going to get myself into these the actual pelvic classes, pelvic 1, 2, and 3, because, I've had a patient where I thought for sure a referral to a pelvic health therapist is what was needed because they were having pain with intercourse. And come to find out, the pelvic health therapist and this is great because this really is their job. And the patient wasn't upset that I, had them take one additional step, but their pain with intercourse really wasn't related to more of a musculoskeletal presentation. It was more about lubrication and those types of things that really were better handled by an OBGYN and not the pelvic health therapist. So, I'm still working on in this area specifically expanding my questions. But I think for, what's important today probably is to start to think about questions beyond incontinence. So, with a male, and you start to think about prostate issues and Parkinson's and diabetes, and with everybody, you really think about all of those things that cause increased intra-abdominal pressure, and kind of just at least considering that bucket can help you figure out what questions you might ask, or even asking the question about, you know, intercourse. Is there any pain with that? At least, starting the conversation, I think is a great first step.
I agree 100% on that. And I find the more skilled I get as a practitioner, the easier it is to have all those conversations. And I never would have thought to ask them earlier on.
Hmm.
I think a big and important point that comes out of part of what you said is the fact that even when we become specialized, we're not perfect. We don't expect to have every referral correct. We don't expect to have every diagnosis correct. But if we are considering this relatively broad number of things, then we're more likely to be correct. And I, in fact, often talk about how healthcare is all about probabilities with my patients. So I might say, based on my skill set, it seems obvious that you have a back problem of some sort. And here's what I think it is. You could also have a pelvic floor or hip or whatever situation going on. And I'll know more in a visitor 5. So let's do these treatments. Let's see what happens. And if I fix half of your problem and half of it remains, and then someone else fixes the other half, then in hindsight, we'll know a lot more about it. But I don't have a crystal ball. So, I can look at you now and I can make an assessment now, but it's going to be better in the future.
Yeah, I'd agree with that completely. And, to think that we have a complete understanding of our patient after one visit is probably not realistic. And so as we look at more things, assess or just consider, or even, just even pay attention to how they're responding to our interventions, then yeah, some of that picture starts to unfold and we can give them a little bit of a clearer picture and a little bit more confidence in the direction we're going.
So, as one final question, well, I guess maybe two final questions. I'm going to assume, and correct me if I'm wrong, that because you're not a pelvic floor specialist, you're not currently doing any research in this realm. Is that correct?
Yes, that's correct.
And do you participate in research at all, or are you more just based in the clinic?
All right, so I'm neither in the clinic nor participating in research related to this area. Currently, I get my clinical exposure and practice working with the residents and fellows in our institution. So, really helping them to identify patients that would benefit from further exploration from either a history standpoint or an exam standpoint from kind of that pelvic floor lens. We do, like I said, have women's health or pelvic health therapists in our system. And I'm not sure if there's any research being developed by them, but I think partnering with them is something I could definitely see myself doing in the future because I think this is just a really fun area. And again, you don't know what you don't know. And so this is an area I think that a lot of us could use some increased knowledge in. And the other thing to think about is even in women's health in general, it's I think one of the fun things about CSM is I like to go to the talks for the groups that are different than my primary piece. So I often go to some of the women's health talks, and they'll even acknowledge there's a lot of opportunity within the realm of pelvic health and women's health for improved research. And the one area they have really good research in is in incontinence and stress incontinence. So ultimately, kind of to answer your question, it's definitely an area that I am continuing to be intrigued by and will clinically through mentoring and potentially with working with our pelvic health therapists, love to explore more research in that area.
Well, when you get involved with that, I'm really excited to see what the research will be and what your results will be. And so hopefully in the future we can have you back and talk about that. Between now and then, if any of our listeners wanted to get a hold of you to ask some questions, how would they find you on the internet?
Currently, I think email is the best for me. I'm not that technological, but you can email me at sarah.cristello@brooksrehab.org.
Excellent. Well, we have been, of course, excited to have you on the show. Thank you for bringing this topic to our audience, and we look forward to hearing more from you in the future.
Thank you so much.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT.